senior faculties, dignitaries present here, and my dear colleagues. Thank you for the opportunity, AMA, for providing me to speak on the topic pregnancy-related acute kidney injury. Today, I'll be discussing on the major outline in view of introduction, epidemiology, physiological changes during pregnancy, how to diagnose pregnancy-related AKI, what are the etiological causes, and the management. First start to begin with, I'll be discussing this patient is currently admitted in our nephrology ward. She is a 24-year-old lady, primary gravida. She was a booked pregnancy and has a regular ANC follow-up. She had LSCS because of some obstetric complications, developed anuria on post-operative day 2. So to begin, I'll be discussing the whole presentation on how to deal with AKI, whether this patient had AKI, what was the etiology in this patient, what are the investigations needed, whether HD was needed, and what is the role of kidney biopsy in this patient. Pregnancy-related acute kidney injury is a heterogeneous disease that occurs due to multitude of underlying etiologies. It is a term defining AKI which occurs during pregnancy, labor, delivery, and or the postpartum period. The question which comes to my mind is, what is the rationale of giving a separate entity pregnancy-related AKI? Why can't we just deal with in the multitude of AKI only? It's because the physiological nature of pregnancy demands identification of any deviation from normalcy upfront. When we talk about a pregnant lady, we should think that we are dealing with two lives, the mother and the fetus inside her. During pregnancy, there are many pre-existing diseases which can worsen, and kidney disease are no exception. And any form of pregnancy-related AKI should raise an alarm and which needs an immediate care, because any delay in treatment will lead to permanent kidney damage or dialysis dependency. It is associated with high rate maternal and perinatal morbidity and mortality. When it comes to the burden of the diseases, the incidence in the Indian studies have been documented up to 3.4 to 14.5%. Mild to moderate renal failure without the need for renal replacement therapy in terms of hemodialysis was 1 in 8,000 deliveries. And as the progress in healthcare facilities has been seen, there has been a declining trend in the incidence of AKI requiring dialysis in these patients, which was 1 in 3,000, and now it has decreased to 20,000 per 1 in 20,000 deliveries. They are the most common cause of referral to dialysis center, which constitute about 25% of these patients. And the mortality varies from 55%, which has decreased now to 8%. The leading cause of pregnancy-related AKI was initially septic abortion, but now in developed nations, it is more of hypertensive disorders during pregnancy, and other in developing countries, which we see nowadays is sepsis, which is postpartum, not post-abortal, most frequently, and the hemorrhagic shock and preeclampsia. The incidence of septic abortion has drastically declined from 33.3% in 1960 to 6.3% in 1990s, but still it is a major concern in the developing countries now also. As we can see, the incidence of AKI has drastically decreased from 1987, approximately 40%. Now it is seen 4 to 8% in the recent studies being done by Gopal Krishnan et al. And Pahava et al. In 2014 and 15. Most cases of pregnancy-related AKI now occur in the postpartum rather than the post-abortal period, as we had discussed earlier, which was initially septic abortion was the leading causes, but now the postpartum sepsis, which is the leading causes, reflecting the decline in the septic abortions and the need for further improvement in the peripartum care. Most of these, 80% of these occurred in the rural areas and were associated with the lack of prenatal care. There are certain discrete features associated with pregnancy-related AKI. Not only we are dealing with the two lives, but there are certain physiological changes which normally occur during pregnancy. After conception, there is an increase in glomerular filtration rate up to 40 to 65% of the baseline throughout the pregnancy, which subsequently subsides in the first 3 months postpartum. which explains a low level of serum creatinine seen in this patient, which can be around 0.4 to 0.5 milligram per deciliter. The diagnosis of acute kidney injury in pregnancy can be diagnosed by the rise in creatinine, but the usual formulas for estimating GFR, the MDRD formula, the CKD API, and the Cockcroft formula, they are not validated in this population. Thirdly, the most important thing, because of the predominant vasodilatation in this patient, which is supposed hypothesized theory, it's not yet proven, the decreased ability of vasoconstriction during postpartum hemorrhage or bleeding loss, there is a risk of bilateral renal cortical necrosis because of overt bleeding losses in this patient, which can eventually lead to end-stage renal disease. These are the scariest patients which we see in our nephrology clinic. Those patients, postpartum patients who come with AKI, they do not improve with the conservative management. Eventually, we do a biopsy in this patient, and the biopsy reports are suggestive of bilateral renal cortical necrosis. Renal cortical necrosis, these patients, they do not have any recovery, and eventually they need transplant or lifelong dialysis support. In pregnant patients, the incidence, usually the incidence of renal cortical necrosis in general population is only 2% of the acute kidney injury. But it is seen that 50 to 70% of the cases of acute cortical necrosis are obstetric complications. So regarding these disease features, if a pregnant patient comes with a creatinine of 1 milligram per deciliter or more than 1 milligram per deciliter, should be considered as normal. A recent systemic review found that using a non-pregnant reference interval of 0.5 to 1 milligram per deciliter, a serum creatinine higher than 0.87 should be considered pathological outside the normal range for a pregnant patient. Now coming to the physiological changes during pregnancy, as we all know, there are certain anatomical and there are certain functional changes which we see during pregnancy. There is an increase in kidney size and volume increases by 30%, size by 1 to 1.5 centimeter. There is a dilatation of the collecting system, and this is the reason 90% of these patients have physiological obstructive features during pregnancy. And the functional features which we see are vasodilatation, the increase in the renal plasma blood flow, the increase in the glomerular filtration rate. Tubular function, there is altered tubular reabsorption of protein, glucose, amino acids, and the uric acid. There is an increased total body sodium, potassium. There is a decrease in the set point of thirst and ADH release. And there is a definite expansion of the plasma volume in these patients. There is a term called physiological proteinuria because of this increased glomerular filtration or the glomerular hyperfiltration, which leads to enhanced creatinine clearance, and increased proteinuria up to 300 milligram per day can be seen normally also in these pregnant patients, and this is physiological proteinuria. This is a state of volume expansion and vasodilatation, the pregnant state. The cardiac output increases by 40 to 50% by 26th week due to increase in both the heart rate and the stroke volume. There is a reduction in systemic blood pressure due to significant decrease in the systemic vascular resistance. There is a decrease in the renal vascular resistance also, because of which the renal blood flow increases by 70 to 80%, which peaks at the end of the second trimester before the decreasing in the third trimester. Consequently, the effective renal plasma flow increases by 60 to 80% mid-pregnancy, whereas the increase in the GFR is slightly less, about 40 to 50% by the end of the second trimester. As such, the filtration fraction, which is the ratio between the GFR and the renal plasma flow, is altered. Decreases in the first half of the pregnancy only to increase in the late gestation and reaching the pre-pregnant values. Now coming to how to diagnose acute kidney injury in pregnancy. As we all know, the creatinine is usually lower than the normal pre-pregnant state, and there are no validated definitions for acute kidney injury in these patients. Secondly, the criteria which we use, as Dr. Santosh has also discussed, the Raffel and the Akin criteria for diagnosis acute kidney injury in the general population, which do not fit in these patients. They are not accurate because of the ongoing physiological changes in serum creatinine, the glomerular filtration rate, and the urine output during the pregnancy. It is being said that a creatinine level of 1 or more than 1 milligram per deciliter or a rapid rise within 48 hours of 0.5 milligram per deciliter above baseline should be investigated. And If a pregnant female usually comes with a creatinine of 0.4, 0.5 1 month before, and she comes after for a ANC visit, and a creatinine is 0.8 or 0.9, then it should also be considered significant, because for that pregnant lady, that 0.4, 0.5 was normal, and there is an intra-variability of creatinine in that patient. So normal creatinine ranges in isolation are not useful for defining the renal dysfunction. Rather, the intra-variability of the creatinine levels in the individual pregnant woman is considered significant. As I had already said, the MDRD equation and the Cockcroft formula, they underestimate then the overestimate the real GFR in this patient. The gold standard for estimating GFR is creatinine clearance by the 24-hour urinary collection. And in this patient, as these patients are have a risk of preeclampsia also, the proteinuria should be evaluated, and it's a compulsory in every antenatal visit. And proteinuria quantification should be done by the 24-hour urinary collection method. It is the gold standard method in these patients. As the ACOG defines the renal insufficiency in the setting of the hypertensive disorders like preeclampsia as a serum creatinine level of more than 1.1 milligram per deciliter, or a doubling of the serum creatinine concentration in the absence of the renal disease. It is seen that these pregnant women may have a 30 to 40% reduction in the GFR without any significant increase in the serum creatinine. There are certain novel biomarkers, as Dr. Santosh has already discussed, for the diagnosis of AKI. So, is there any role of cystatin C as a novel biomarker for these patients? No, cystatin C is not validated in pregnancy. Moreover, the levels are seen to increase in the third trimester of pregnancy, and even in the twin pregnancy, the levels are more than the singleton pregnancy, because cystatin C is supposed to be produced from the nucleated cells, including the placenta. So increase in the placental mass is the reason for the increase in cystatin C levels in these conditions. What is the role of the kidney biopsy? Kidney biopsy is almost never necessary for diagnosis acute kidney injury in pregnancy. Appropriate history, examination, and special investigation, they can reveal the diagnosis. They are only reserved for severe pregnancy-related AKI without other clinical clues and anticipated diagnosis with established therapy, or when the prolongation of pregnancy is a priority, such as in the second trimester. Usually, biopsy in our patients we do when we suspect a glomerulonephritis flare. When we suspect the patient has come in the nephrotic syndrome and she's not responding to the immunosuppression, because we can give safely certain immunosuppression like steroids in these patients. And if the patient is still not responding, then we can go ahead with the biopsy. Thirdly, in the postpartum period also, we look for the causes, the reversible causes in these patients like sepsis. Most common, they'll end up with sepsis. Once we treat the sepsis, most of these patients, the AKI recovers. But if the AKI is not recovering and the patient is afebrile, the counts had settled, still the patient is anuric or the creatinine is not settling, then we go ahead with a biopsy for the reason of acute kidney injury, because there are certain conditions which can only be diagnosed with a kidney biopsy. Coming to the etiology of acute kidney injury in pregnancy, there are certain disorders or diseases which are specific to pregnancy, and there are certain diseases which may affect a reproductive age group, non-pregnant female also. It is seen there is a bimodal distribution. There is an increased incidence of acute kidney injury in the first trimester, which is mainly because of infections or the hyperemesis gravidarum, and the third trimester due to the late obstructive complications. Coming to the etiology, as in the previous lecture, we had seen that the causes of acute kidney injury can be classified as pre-renal, renal, and post-renal. Coming to the pre-renal cause, we have vomiting or the hyperemesis gravidarum, the postpartum hemorrhage, the placental abruption, sepsis, and heart failure. The renal causes include the preeclampsia, HELLP, acute fatty liver of pregnancy, acute tubular necrosis, which is most commonly due to the sepsis ongoing, interstitial nephritis, thrombotic purpuras or thrombotic microangiopathy, including the TTP and atypical HUS. Post-renal causes can be the gravid uterus, papillary necrosis, urinary retention, and the damaged ureter. Whereas in the developed countries, pregnancy-induced hypertensive disorders are the leading etiology, but in a developing countries, sepsis and hemorrhage are still the main contributors of the pregnancy-related AKI. Considering the timeline of etiology, we have first trimester, second trimester, and third trimester in the postpartum period where the patient can have they can develop AKI. As we can see, septic abortions and the hyperemesis gravidarum are mostly seen in the first trimester. Pyelonephritis or urinary tract infection of the kidneys, they can be seen in either of the trimesters. Cortical necrosis usually occurs because of sepsis or the postpartum hemorrhage, or the antepartum hemorrhage can be seen in the third trimester. Other disorders like preeclampsia, thrombotic thrombocytopenic purpura, obstruction, they can be seen from the second to the third trimester. And glomerulonephritis flare, like the lupus nephritis flare, can be seen in either of the trimester, including the postpartum period. Coming to the individual specific diseases which can cause the pregnancy-related AKI. Coming first to the preeclampsia. Preeclampsia is a syndrome characterized by the onset of hypertension and proteinuria after 20 weeks of gestation in a previously normotensive woman. The incidence is 3 to 8% of the pregnancies in the developed countries, and it is one of the major sources of maternal, fetal, neonatal morbidity and mortality worldwide. It can be diagnosed as a systolic blood pressure of more than or equal to 140 millimeters of mercury, or a diastolic more than 90 millimeters of mercury on 2 occasions at least 4 hours apart after 20 weeks of gestation in a normotensive female with proteinuria which is more than or equal to 300 milligrams per day, or the spot urinary protein creatinine ratio more than 3 milligram per deciliter, or a urine dipsticks having a reading of 2+, which can be used only if other quantitative methods are not available. If the proteinuria is not available, then we can diagnose as a new onset hypertension of more than 160 or diastolic blood pressure of more than or equal to 110 millimeters of mercury on 2 occasions at least 4 hours apart, or there is a presence of thrombocytopenia or the renal insufficiency as said by the creatinine more than 1 milligram per 1.1 milligram per deciliter, or doubling of the serum creatinine concentration in the absence of other renal diseases, or suggestive of impaired liver function as the liver transaminases more than 2 times of the upper limit of normal, presence of pulmonary edema, or new onset of headache or visual symptoms. The pathogenesis which is implicated in preeclampsia is believed to occur due to the incomplete cytotrophoblastic invasion of the uterine spiral arteries, which leads to an ischemic placenta and eventual release of the inflammatory factors, immune cell activation, and the endothelial dysfunction. Actually, it is because of the placental hypoperfusion which is implicated in the release of the complementary pathway and the inflammatory cascade and cytokine activation. Long thought it was primarily as a disease of hypertension, it is now well recognized that preeclampsia is actually a multi-organ syndrome. Normally in the pregnant, the placenta releases both the pro-angiogenic and the anti-angiogenic proteins and mediators. Pro-angiogenic factors include the vascular endothelial growth factor, the placental growth factor, and the anti-angiogenic include the soluble FMS-like tyrosine kinase 1. And the balance between these two determines the normal placental development. It is also being said that the soluble FLT1 is increased in placenta and the serum of the preeclamptic woman, and which binds to the vascular endothelial growth factor and the placental growth factor, preventing its interaction with the endothelial receptors on the cell surface. Placenta also releases the soluble androglin, which is an anti-angiogenic, and it has a role both triggers the endothelial dysfunction and causation of the severe preeclampsia. The triad of the placental ischemia, the reperfusion, and the oxidative stress, it amplifies the apoptosis by the rupture of the syncytial architecture, which eventually releases the syncytotopoblast membrane microparticles and an excess of anti-angiogenic factors, SFLT1, into the maternal circulations, and which leads to the synthesis of inflammatory cytokines, which as a result leads to increased vascular reactivity and coagulopathy that precedes the development of this symptomatic disease in the preeclampsia patients. As we can see, there is a hypoxic damage of the trophoblast tissue and the exaggerated state of the oxidative stress and inflammation in the placenta, due to which the inflammatory cells are being released in the circulation, interacts with the complement cascade, and which leads to the decreased nitric oxide and cell proliferation, and eventually all the symptoms which are related to preeclampsia. What are the clinical manifestations? Mostly the clinical features are non-specific even in the severe diseases. They can present with the right upper quadrant pain or epigastric pain. Renal involvement is common in these patients. They have a decreased renal plasma flow and GFR by 30 to 40%, but the serum creatinine may be normal or only slightly increased, except in the severe preeclampsia patient. Earlier stage renal tubular function is also damaged and it is impaired, and even the early dysfunction of uric acid tubular secretion in be seen. Hyperuricemia is associated with the renal histological lesions, clinical severity, and the fetal survival in these patients. Management, when we talk of management, if the gestation age is more than equal to 37 weeks, we have to deliver the child. But it is less than 37 weeks, and the indications for delivery include the progressive evidence for maternal organ dysfunction, worsening renal or hepatic function, worsening thrombocytopenia, and development of neurological symptoms like development of eclampsia or seizures, or signs they have inability to the control of blood pressure, failure of fetal growth, or concern about the fetal status. And as we have discussed, the gestation age more than 37 weeks should be terminated. Generally, the prognosis is favorable for women with mild preeclampsia, but severe preeclampsia is associated with maternal, fetal, and the neonatal complications. The most frequent maternal complications are DIC, HELLP syndrome, pulmonary edema, AKI, and the placental abruption. Second, we come to the HELLP syndrome. Traditionally, the HELLP syndrome was considered to be a variant of preeclampsia, but it is in fact a distinct disease, since 20% of the pregnant women who have no history of hypertension or proteinuria develop HELLP syndrome. The diagnosis can be made as a microangiopathic hemolytic anemia by the presence of schistocytes in the blood film, or the elevated serum bilirubin or lactate dehydrogenase or low haptoglobulin levels, increased liver enzymes as AST more than 70 or 2 times of the upper limit of normal, platelet count less than 1 lakh. Third entity of the pregnancy-associated specific diseases causing AKI is acute fatty liver of pregnancy. It is a rare non-thrombotic microangiopathic obstetric emergency, which if left unattended can lead to fulminant liver failure. Incidence seen as 1:7,000 to 1:15,000 pregnant women a year. They are most commonly seen in the third trimester of pregnancy, but they can also occur during the postpartum period. There is a defect in the mitochondrial beta oxidation pathway, which leads to increased load of long-chain fatty acids, which get deposited in the liver tissues and leads to impaired hepatic function in the mother. However, half of these patients have signs of preeclampsia HELLP syndrome. At an early phase, the differential diagnosis may be very difficult. Liver biopsy allows for definitive diagnosis. The early symptoms which they present are nausea, vomiting, and abdominal pain. And other signs settle in as the disease progresses, for example, jaundice and hepatic encephalopathy. Women with acute fatty liver of pregnancy, they may also present with thrombocytopenia with or without DIC, hypoglycemia, intra-abdominal hemorrhage, or central diabetes insipidus. 60% of these patients, they develop AKI, but most of them is very mild and rarely they require hemodialysis support also. In most women, there is complete liver and kidney recovery after delivery. However, it is associated with an important maternal and perinatal mortality risk. The most important in the last pregnancy disease specific related to AKI are the thrombotic microangiopathy. Pregnancy-associated thrombotic microangiopathy, they are rare. They are affecting 1 per 25,000 pregnancies. They can be defined by the presence of fibrin or platelet thrombi in the microcirculation of the multiple organs. It can be TTP, it can be atypical HUS, or it can be HELLP syndrome. TTP usually occurs because of the deficiency of ADAM-TS13, and atypical HUS usually occurs because of the dysregulation of the alternate complement pathway. Usually, it is seen that TTP, the neurological involvement is more as compared to atypical HUS, where the renal involvement is predominantly seen. It presents with the syndromic diagnosis of fever, thrombocytopenia, microangiopathic hemolytic anemia, mild renal failure, and neurological symptoms, which may include disorientation, ataxia, headache, focal changes, and seizures or aphasia. ADAM-TS13, which is the von Willebrand factor cleaving proteases, it's deficient and it is a leading cause for the TTP in these patients. Second, we come to atypical HUS. As we can see, this is the renal biopsy. Diagnosis can be made as a renal biopsy showing a thrombotic microangiopathy or the classical triad of microangiopathic hemolytic anemia, thrombocytopenia, and renal failure. Chronic relapsing entity, and it is triggered by an uncontrolled complement activation. Historically, 15% mortality and 50% they never recover the renal function. So it is a scarier disease because most of the patients, they end up in end-stage renal disease and they require renal transplantation. And 50% they have a recurrence even after renal transplantation. When we compare between the atypical HUS and the HELP syndrome, hemolysis, elevated liver enzymes with a low platelet count, we can see they both are a spectrum of TMA in the pregnant patient, but there are certain distinguishing features in both the entities. As we can see, the atypical HUS patients, they have normal LFTs and they have a severe hemolysis, but these HELP patients, they have a mild hemolysis and they have abnormal liver function tests. The platelet count is very low in the atypical HUS patient, less than 20,000, where it is moderately low in the HELP patients. Less than 1 lakh is the diagnostic criteria, and mostly they are seen as 80,000. The coagulation parameters are normal in atypical HUS, but coagulopathy is seen in 20% of the HELP patients. The condition of atypical HUS, it is because of the dysregulation of the alternate complement pathway. So it is not going to improve after delivery. But in HELP, it improves spontaneously after delivery. The treatment of atypical HUS is plasma exchange or eculizumab. The plasma exchange, it aims to replace the mutant dysfunctional proteins with normal proteins. And we have to start with plasma exchange while awaiting for other results in these patients. But unsuccessful, usually the complement regulatory proteins, they are useful plasma exchange in all the patients, unless there is a presence of anti-factor antibody driven, in which the plasma exchange is also unsuccessful in majority of these patients. There are certain differentiating features among the pregnancy-specific causes of related AKI, the HELP syndrome, the atypical HUS, TTP, acute fatty liver of pregnancy, and DIC. As we can see, earlier entities, they can be seen in the third trimester or the postpartum state, but DIC can be seen at any time. And most commonly, it is because it leads to an obstetric catastrophe. The symptoms are generally non-specific. Hypertension is present in HELP. In atypical HUS, moderate hypertension may be present, but usually it is mild and absent in DIC. Proteinuria can be seen as severe in HELP syndrome. Atypical HUS, severe proteinuria can be seen. Hemolytic anemia is a spectrum of part of HELP syndrome and atypical HUS, but mild hemolysis can be seen in AFLP. Hypoglycemia is usually absent in HELP syndrome, atypical HUS, and TTP, but they are present in the acute fatty liver of pregnancy and DIC. As we see, the complement dysregulation is seen in atypical HUS, so the levels of complement are decreased in atypical HUS. ADAM-TS13 levels are decreased in TTP because this is the etiological agent. And DIC, the plasma clotting or coagulation factors are prolonged. Now coming to the AKI treatment in pregnancy. There are three aspects to consider while managing a case of AKI related to pregnancy. First, we have to give the renal function support measurements. Secondly, the need for dialysis. And thirdly, the treatment of the underlying cause. Immediately, we should suspend all nephrotoxic drugs and treat the infectious etiology being going on in the patient. Secondly, we should administer IV fluid to restore renal perfusion to prevent hypovolemia and ensure an adequate uteroplacental perfusion and the fetal well-being. Diuretics should not be used to prevent or treat AKI. The role of diuretics is only to convert the oligoanuric AKI into non-oligouric AKI and halt the rate of dialysis AKI patient, but they do not correct or rectify the underlying disease process being going on. So in diuretics should not be mortality. Role of dialysis. The patient who do not respond to diuretic therapy or in those who develop progressive volume overload despite the fluid restrictions and diuretic therapy, they remain anuric and develop azotemia. They are the candidates who require hemodialysis in our patients. There are certain peculiarities in terms of renal replacement therapy or the hemodialysis in pregnancy-related AKI. First, it is often prescribed for a short time. Usually these patients recover, the AKI recovers, and the need for dialysis is stopped. Increase in the duration and frequency of dialysis session is recommended, targeting a serum urea between 45 to 60 milligram per deciliter. Even 20 hours per week of dialysis is being given in these patients to target the urea level in this range. Aim is to avoid excessive fluid shifts and hypotension, which can affect the feto-placental circulation and influence the fetal well-being in this patient. Now, coming to our case, this patient, she's a 24-year-old lady and she had anemia. So definitely she has developed AKI. What is the diagnosis? We'll get some laboratory tests done to get the diagnosis and etiology. As we have seen, the patient was an ANC follow-up and she was a book pregnancy and a regular follow-up. She didn't have any history of proteinuria or hypertension during pregnancy. So she's a clean case. She's not having any hypertensive disorders of pregnancy. Now she has developed LSC, she has undergone LSCS and developed anuria. The lab parameter is suggestive of there is anemia. There is a TLC count of 40,000. She has developed sepsis and the platelet count was normal. As the platelet count is normal, the patient is not having thrombocytopenia. The peripheral smear was also done, which was not suggestive of any microangiopathic hemolytic anemia. So we had ruled out TMA also. The provisional diagnosis in our patient is sepsis-related AKI. And we had managed this patient on this basis. She required dialysis because she was anuric and she continued to be anuric even till today. It's been 2 weeks of her AKI, and despite sepsis being corrected, we did a kidney biopsy because there was no further focus of sepsis. There was no other causative agent, no nephrotoxic drugs being given, and no other etiological agent which can cause AKI in this patient. And once we get the kidney biopsy report was suggestive of acute cortical necrosis. So unfortunately, there's not going to be any recovery in this patient. It is a diffuse cortical necrosis. The patient is still anuric and she might require renal replacement therapy in terms of hemodialysis or renal transplantation in future. To summarize, acute kidney injury in pregnancy, the major clinical challenge because it considered two patients, the mother and the fetus. It can be caused by specific pregnancy diseases which are not yet fully understood. We should focus on the prevention and the periodic evaluation of the pregnant woman. The complexity of the AKI in the pregnancy requires a multidisciplinary approach where the nephrologist plays an important role. Thank you.